Bismillahirrahmanirrahim. Today we will have case quiz number 114. Case data: 17 weeks gestational age fetus, so intrauterine fetus with 17 weeks age with significant shortening of long bones as you see in this X-ray, and this is the histology of a specimen of the fetus bone. This is the only data of this case. So, what is the diagnosis? Remember that this case is not a rheumatology case. It is an orthopedic case, not a rheumatology. But you may be faced with in rheumatology clinic or rheumatology consultation. The answer is osteogenesis imperfecta type 2. Osteogenesis imperfecta type 2. I think I remember that we have a case of osteogenesis imperfecta, but in young child, not an intrauterine fetus as this case. Discussion of the diagnosis. The skeletal dysplasias represent a large group of disorders with a broad range in severity. The most severe forms are the lethal skeletal dysplasias, which present in the fetus and can be diagnosed in utero. The lethality of these disorders typically derives from the very small chest cavity that develops in these fetuses. The resulting constriction in lung volume leads to severe pulmonary hypoplasia and nearly uniform perinatal mortality. The most common lethal skeletal dysplasias include atophoric dysplasia, which is the most common type, achondrogenesis, osteogenesis imperfecta type 2, as in this specific case, hypophosphatasia congenita, campomelic dysplasia, short rib polydactyly syndrome, fibrochondrogenesis, atherosteogenesis, and chondrodysplasia punctata. Atrophic dysplasia and osteogenesis imperfecta type 2 together account for about 30% of lethal skeletal dysplasia cases. Prenatal diagnosis of lethal skeletal dysplasias involve a comprehensive evaluation, which usually starts with the anatomy scan in the second trimester. If concern for a skeletal dysplasia is raised, the follow-up diagnostic process includes a thorough ultrasonographic evaluation of the bones, absence or presence, length, fractures, shape, and growth over time. Currently, prenatal diagnosis using ultrasound has very high sensitivity and specificity for the diagnosis of lethal skeletal dysplasias. Cases of suspected lethal skeletal dysplasia are typically referred for a genetic consultation and ancillary testing, such as amniocentesis with karyotype and possibly molecular testing may be recommended. After delivery, clinical, radiological, molecular, and pathologic examinations are employed to confirm the diagnosis. Pathologically, this is a typical osteogenesis imperfecta type 2 case. This disorder presents with multiple, sometimes almost innumerable fractures in the ribs and long bones with consequent malformation of the bones. Microscopic and radiological examination show deformed upper and lower extremities with shortened long bones with multiple fractures. The ribs will often have a beaded appearance due to the multiple adjacent fractures. Radiologically, the bones have a crumpled appearance. All bones are extremely delicate and easily fractured. Histology of the long bones show thin cortices with small thin hypocellular trabeculae and often extensive metaplastic cartilage. Most cases of osteogenesis imperfecta type 2 or OI2 are autosomal dominant. The disorder arises from mutation in one of the two type 1 collagen genes, COL1A1 and COL1A2. Nearly all are new mutations, with the parents being unaffected. A smaller number of cases show autosomal recessive inheritance. The first of these to be identified was the gene of cartilage-associated protein CRTAP gene. This protein appeared to be required for prolyl 3 hydroxylation of type 1 and type 2 collagens. More recently, mutations in other genes have also been associated with autosomal recessive osteogenesis imperfecta type 2. These include LEBRE1 and BPIB. The autosomal recessive forms of osteogenesis imperfecta type 2 may have a milder phenotype than the autosomal dominant form. The autosomal recessive form were originally designated as osteogenesis imperfecta type 2B, with the autosomal dominant form as osteogenesis imperfecta type 2A. More recently, however, severe new categories of osteogenesis imperfecta have been developed, and the autosomal recessive forms of osteogenesis imperfecta type 2B have been reclassified as osteogenesis imperfecta type 7. And finally, I know this case is strange for you, and you may not be faced with this case in usual rheumatological practice, but you may be aware of other problems in the relating specialties such as orthopedics. And finally, thank you very much for your attendance, and we will meet you tomorrow inshallah with case quiz number 115. والسلام عليكم ورحمة الله وبركاته.